Okay, well, I'm delighted to have this opportunity to talk to you about some of the work that we've been involved in, working with frontline teams to help them implement local solutions to improve quality and reduce costs. So I'm working with the Health Foundation. I haven't been there quite 18 years, but I've been working in quality improvement for 18 years, 4 years now nearly at the Health Foundation. We're an independent charitable organisation. Our mission is to improve the quality of healthcare in the UK, and we do this through a number of approaches, as listed, as sort of categorised in 3 groups there. Supporting research into quality improvement, supporting people to lead and build their skills in quality improvement, and making grants to develop and test quality improvement interventions in healthcare. And it's some work in that third category that I'm going to share with you today. Now, I think you have been at this conference now for 3 days, so I won't labour the point, but obviously these are some of the issues that across the world we are grappling with. And obviously, if we want to improve the quality of healthcare, we need to think about improving the quality, but within this context. And so for an improvement programme that we started in 2010, we set a challenge. The awards were called Shine Awards, just letting ideas shine. It's not an acronym for anything. And the challenge was to find new approaches to delivering healthcare whilst improving quality and saving money. So this was the challenge. And this really came about because of some of the thinking that had already been going on, as James said, this idea of improvement needing to improve the value of healthcare as well as the quality was something that we were aware in the Health Foundation that we had not really looked at improvement through that sort of lens of, is the improvement having an effect on costs? But obviously 2008 the world changed very much, and we all had to start looking at costs and thinking about, if we're making a change, we need to know what is the cost of that change. And so we asked the question that it's intuitive. We kind of had assumed that if we were improving things, it would be reducing costs. But what's the evidence for that? Is that supported by research that has been done? And so we commissioned John Overtveit from the Karolinska Institute in Stockholm to review the evidence and see what was out there, what had been found out about how improving quality reduces costs. And the answer was not a lot, which doesn't mean to say that it's not true, simply that the research has not been done. People have been, with the best will in the world, developing ideas and approaches that will improve the quality of care, but they have not had sufficient focus on cost, and so there really is very little evidence. And this report is from 3.5 years ago, but even in the last 3.5 years, I think there's still little evidence that really demonstrates the proof of this. And that improving quality in the way it's been approached to date can make a limited contribution to addressing financial pressures, and that links back to the message of that John put to us, that we're not looking at the whole patient pathway, that improvements have been in small parts of healthcare, and therefore the sort of work that we're doing, and in fact that the Shine projects have been involved in, they're going to make a small contribution, but it's very important to test these ideas, see where they work, and then see how we can link those together over the pathway and how to scale up, etc. So Shine projects are very much about testing new ideas at small scale. And these are some of the other general findings about how to make those improvements and what's going to increase your likelihood of success. And what the report did note, that where there was some evidence, it was pretty weak, and that the way in which quality improvement has been reported has tended to be anecdotal, with not sufficient description on the context or the methodology for people to know how well what was being reported would work in another setting, and also exactly what was done. So there's a real weakness in the way we've been reporting this work. We're all success junkies. there's this reporting bias to report things which have been successful and not publish results of interventions which have been tried and failed. I think, again, there's been some really important work done in the last few years which has looked deeply into some initiatives that haven't achieved what they set out to do, and I think we're learning more from that. And the improvement is described disproportionately with very little information or even knowledge of whether there's been any cost benefit. So, seeing that was what the evidence was telling us, we decided that one of the things we could do within this award programme was to encourage more innovation, looking at improvement through the lens of costs, and also try to ensure that we really captured the experiences of these projects so that we could learn from them. And we were particularly wanting to encourage clinical ownership of the cost agenda, so that people with the projects led by frontline clinical teams would be trying to understand how they could have an impact on the cost of service delivery and how they could reduce those costs, reduce waste in what they were doing without it having a negative effect on the quality of the service provided. So here's an outline of the funding programme that we put in place to stimulate this activity. So an open competition for anybody working in healthcare. The funding awards were £75,000, and that was to ensure that we covered people's time, but we weren't at that level of funding. We weren't paying for the development of technology, the development of new devices, or anything at a large scale. So it was deliberately done at a small scale. There was a lot of interest. 400 clinical teams have applied for these awards. 32 projects are now completed. We've got a further 30 underway, and we think they have been pretty successful in demonstrating new ideas, and we were looking for teams that also showed that they would have the skills to put those into action. And one of the things that we learned between the first two funding rounds, and something that came up in a session I was at yesterday, was in the second round we insisted that there had to be a member of the finance team on the project team, from someone from finance working with the clinical team to help them understand the costs and how they were measuring the costs, and really get into the understanding whether the change was it saving money, was it done for the same amount of money but there were other benefits, or was it actually costing more than the service as normal. And so that was something that was very important that we wanted to see on the teams that we were funding with the awards. So, the improvement opportunities that were identified, having looked across all the project, the themes that really have emerged is that the services, you can do these sort of improvements fairly quickly. I didn't put in that slide that these projects had to be initiated and show some results within 15 months. So we were looking at a small amount of funding and getting something in place, and with some data that could show what effect that change was having. And so the themes that emerged was that people could change the location of where a service was carried out, and this was very much about moving things from high cost, high intensive situations to lower cost environments. So seeing procedures moving from operating theatre into outpatients, seeing checkups and intensive care for people with heart failure moving from an inpatient stay to a half-day outpatient visit. So changing the location, really just thinking, yes, we've always run this service in this environment, but is that really necessary? Is there a better way that will cost less, and is usually, if you move the service, it's often less invasive for patients and gives them a more convenient and more accessible way to access the service. We've been particularly keen to see better use of what I'm calling existing IT. So this is not about developing new technology, it's not about fancy equipment, it's about using what's there and using it better. And certainly the health system in the UK has been woefully slow to really realise the benefits of technology such as smartphones, Skype, just generally using the web better. So that's what we were looking for. You've got the equipment there, patients have the equipment, how can you not get better use out of this without it costing a great deal? And looking at the best use for staff roles. So we've seen projects that were particularly focused on making sure that the most experienced staff see the most complex patients. Sounds really sensible, but many services don't automatically have that system. They have a system of the most junior person sees the patient first and then they're passed up the line, whereas you can cut out a lot of stages of care, and this is what we're talking about, cutting out waste in the system, unnecessary stages of repeat consultations, people being passed up the line if you put the right member of staff with the appropriate patient, the appropriate member of staff in the first instance. So, looking at ones that changed location and delivery, I've already mentioned the heart failure clinic. Interestingly, this came about because the new hospital already had fewer beds. So they were really pushed to think about how to change services that had been traditionally run on an inpatient basis to outpatient day case. And when they looked at following up people with acute heart failure, people were coming in to have a series of tests and have their medications modified, and it was generally, they worked out, it was a 5-day visit, and then they looked at how much actual clinical interaction happened in that 5 days, and realised that, of course, if you got the flow right, if you get your services all lined up, you can do that in half a day. And unsurprisingly, the feedback from patients was very, very supportive of this, that they really appreciated not having to be in hospital, and that this was a classic case of changing the way the service was organised. So it really focused on, here's the patient, and bring all the services and the tests and the right staff to the patient in that half-day visit. Likewise, we had a urology outpatient department where people were coming in on a first referral and then having to have 3 and sometimes 4 appointments for different tests, coming back for different tests, waiting till all the test results were there, sometimes seeing a consultant before one of the test results was there, so then they actually had to come back and have a second appointment with a consultant because the consultant didn't have all the information. So again, they just looked at how is that organised and put in place what they call their one-stop shop methodology, which meant that people were coming for longer. It was 3 hours, but they were able to tell people this will be a 3-hour appointment, and again got it lined up so that the tests happened in the right order and nobody saw a consultant before all those test results were there and available. Very intensive chemotherapy for hematological cancers. We saw that reduced from a 25-day inpatient stay to, again, just think about how they changed that. So some of that care could be given on an inpatient basis, and then it was a much shorter inpatient stay, so 7 to 11 days, as opposed to the 25-day average that had been the norm before. And where people live too far away to be able to conveniently and safely come into the hospital for day care, this organisation developed flats on the hospital site, but again it was a much more cost-effective environment for those people to be in while they were effectively having day treatment, and it meant that people didn't have that feeling of being locked into the hospital when they weren't having their treatment. They were able to have family with them, were able to go out for short trips, cook their own meals, and so on. It just made that whole very horrible experience of having that very intensive chemotherapy a lot more bearable. And again, looking at another procedure where we moved the setting, and this was a team from Cardiff where the gynecology service moved one of their procedures, a hysteroscopy, from a theatre it was being done as a day case, but a theatre procedure to an outpatient procedure. And here's the team, and it's reported in this Health Foundation publication, which you can download from our website. So what did it take to do that? It's all very well saying, oh yes, they did that, they did the other. I've only got time to go into a couple of examples, but just to let you know a little bit about what the team did to make this change. Well, first of all, obviously a risk assessment. You can't just move everything from inpatients and theatre procedures to outpatients. So is it safe? Really doing very proactive, very detailed risk assessment to consider, well, what could go wrong? How can we make this safe for patients? Obviously, not obviously, but in many cases people would have to upgrade the facilities in terms of the actual physical structure, and certainly you need to make sure that you've then got exactly the right equipment in the outpatients department, because it's not going to be normal equipment for outpatient visits. And one of the big, it's an innovation, not that it involved anything new, it was just about a new way of using existing equipment. And the reason, as you'll see in a moment, why this particularly saved costs was because they used reusable equipment, whereas as a day case procedure in the past, the hysteroscopy had always been done with disposable equipment, and obviously there is a big cost to that. Outpatient nurses needed additional training, and that had to be provided and make sure that they were fully upskilled to do this new role, and all of that then had to be encapsulated in written protocols and procedures, which were then approved as being a safe way to practice. So we have got some data on the comparative costs here, and there are option A, which is the new way of doing this as an outpatient procedure with reusable equipment, comes out by far the cheapest at £313 per procedure. And the other options, for obviously the theatre with general anaesthetic is much more expensive because of the staff you need to do that, and that is the big cost there, obviously, is staff and the cost of the theatre environment. Local anaesthetic in theatre, you need fewer staff, so that comes in a bit cheaper, and previous ways in which people had done this as an outpatient procedure was with the disposable equipment, but that's, as you can see, about 10 times more expensive than the reusable scopes. So in this project, we're able to look at the resources used, and that's how they've come at those costs, and they worked with a local health economics team to make sure that they were checking those figures and have some help with understanding how you can get to those figures, extrapolating those costs from overall budget, departmental budgets, which are not broken down to this sort of level. And so you've got to look at how can you create these sorts of costs, and then check that they really are as accurate as they can be. You haven't overlooked something, which means that you're working on false assumptions. So very important when testing these ideas to really have that expert input from people who can help understand the costs and how to express those in a way that everybody can get to grips with it. And that really, I think we have discovered that is what most of the teams have really struggled with, to get any sort of really viable and understandable costs, and to be able to then make a convincing business case for the continuation of their work or the spread of it to other departments, other organisations, based on really robust costing information. Obviously, it's very interesting to fund small-scale projects and see what local teams can do, and that's very empowering for them, and they can improve locally in what they're doing. But what we really want to do is try to get some good examples of ideas which can then be taken up by others. And this, again, I'm sure many of you know, this is the really, really difficult work of quality improvement, moving from that small project to something that can be taken up and used by others. And this is the sort of the starting point for that. One has to make a projection as to make some detailed data about what has been saved locally. I mean, that's normal procedure now. There are about 150 cases a year. So looking at how much you're saving based on those costs, you then get a figure for this unit. And then it's looking at the other benefits, because you're doing something in a more effective way and in a more effective place. You're getting opportunity costs as well. But it's then a huge step to then suggest how much you can save across the country. And it's very, we need to start thinking about what the potential is, but we have to realise that that's only a potential figure, and there's a lot of work, a lot of steps in between to getting to that. So just a few examples of use of existing IT. Diabetes follow-up appointments by webcam, that was presented at this conference last year, and that's been very successful and has spread to other services. Using phones has been really important, doing text messaging, and 2 projects did that. One for alcohol recovery, and one that I'm going to tell you a little bit more about. And we also saw a web-based cardiac rehabilitation program, which meant that people could access that as and when and where they wanted to do their rehabilitation, not having to turn up at a preset class. So this was text messaging for self-management, and particularly focusing on hypertension, and interestingly quite similar to the methodology that we heard about in the plenary this morning. People monitoring their blood pressure, automatically texting those results in. The automatic system notes whether that's normal or high, and then switches onto response back to the patient if it's high, so that the patient can then come into the clinic if they do need some expert help with managing that. So what they found was any patient with a mobile phone was able to take advantage of that. And I think it disproved some of the myths that older people, don't have and can't use mobile phones. A lot of people felt much happier doing this, a lot less flustered than going to the surgery and having the doctor or the nurse with the equipment and being in the surgery. They could calmly take their blood pressure at home and found it stress-free. And again, a cost benefit of £5 a patient for 12 weeks on that system, as opposed to a cost that was estimated at £24 for a surgery visit. And as you'd expect, something successful, that's rapidly been expanded to other conditions where keeping in touch with the patient, helping them self-monitor is really important. So one of the things would like to ask you to think about is, where are your opportunities to improve quality and save costs? And I think there will be, if you looked at what's currently happening and really question, does this need to be done in the hospital? Many things that could be moved out, but of course what we have to realise is, and what often happens, is that we start doing a service that is then out in the community, but we continue to run all the hospital services. So that is actually adding cost. It's increasing patient choice, making it more accessible for some people, but it's adding cost. It's only when you make this shift that you're actually able to save anything. But certainly looking at how you can improve flow. 60% of your patients in most countries, and that is true across most of the developed and developing world, the use of mobile phones it's enormous, and certainly in the UK we've got the highest usage of any country in the world. So to not bring about an innovation out of a fear that some patients may not have access to a mobile phone is really poor thinking. Put the innovation in place for those people that can use it, and sure, have a backup for anybody who's not using a mobile phone. But it's really a lost opportunity to put up these barriers to innovation because you feel you have a fear that they may not be equitable. So what did we find? It was really true that of the 32 projects that have finished, 30 of them could, through the metrics that they had got, a lot of questionnaires to patients, looking at how they'd improved access and so on, they had the data to show that they'd improved quality. But people are much more comfortable with those metrics than with costs. as we've heard, costs, they're hard to define, they're hard to get at, and it's hard to demonstrate impact. Like, where's the real money? And you need to be really clear when you're doing this sort of work. Have you actually saved money? And probably the ways that you will initially save money is by reducing some medication cost, by getting better and more appropriate use of medications, and actually cutting some of the use of medications. Some prescriptions don't happen, or have you been able to cut some sort of consumable out of the care? If you're saving staff time, until you actually reduce the number of people working in that service, you haven't actually saved anything. And even if you've reduced staff time, you need to think about where's that extra time doing? Have a use for it, or else you really haven't saved anything, and you haven't, at a system-wide level, got the benefits from your improvement. So from the outset, if you think one of your metrics is saving time, have a very clear use for how you want that time to be better spent to continue to improve quality and increase value. So there are our conclusions. These are small-scale projects, and work on this scale, it's not going to be the solution to those massive problems, but it is a step along the way. It shows what can be done, and people need to be encouraged and freed up to try these things and show that they can make a difference, to get interested and proud of how they can increase value as well as quality, and then move on to bigger steps which will start to solve those challenges. And just to let you know that we've got one publication with 3 case studies written up, and also you can access information on all of these projects from our website. Thank you very much.
Thank you very much indeed, Helen. Howard, a quick comments from Twitter there?
Yeah, so just to summarise some of the comments coming through, people feel that we need to look at the whole pathway if we are to realise value, and that it really is the flow through the system that matters. It's also a feeling that we should be empowering staff and patients to ensure that that flow does happen and not to micromanage things. And there's also people drawing parallels with the service industry, and to ensure that we are focusing on experience but not making healthcare a commodity.
Howard, thank you very much indeed. Just to say, Howard is a psychiatrist. Twitter will be open over lunch for e-consultations, and we'll be applying for a grant to Helen. Ladies and gentlemen, enjoy your lunch. Thank you very much indeed.